Yes, this entity of the acute kidney injury was earlier known as acute renal failure. And when a patient with acute deterioration of the renal function that has happened over few hours or a few days, the entity was known as acute renal failure. And invariably, it has led to the accumulation of the nitrogen substances which are normally excreted by the kidney, such as urea and creatinine. And this was accompanied by the decreased urine output. But we have seen later on that not all the patients with acute renal failure, they have the decreased urine output. So they call a non-oliguric kind of the acute renal failure. The term oliguria is used when the urine output over the 24 hours is less than 400 ml. So what has the current definition, which is being used by a consensus opinion, that that patient will be said to have acute kidney injury when there is increase in serum creatinine by 0.3 milligram per deciliter over the last 48 hours, or at least there is rise of serum creatinine more than 50% of the baseline within a 1B. So, when you are knowing a previous value, then you will come to know that there is increase in serum creatinine. So if you know the previous value and then there is a increase by 0.3 milligram per deciliter 48 hours, you can label it. But sometimes it is not available. So you keep on observing the patient, and when you see that it has gone 50% higher than the baseline value for the week, you can call the patient acute kidney injury. Then not only does the serum creatinine value, which is a marker of the urine filtration rate, that urine output also tells you about whether the patient has AKI or not. If a patient has decreased in urine output more than 0.5 ml per kg or per hour for longer than 6 hours, you can label this patient as an acute kidney injury. Conventionally, this acute kidney injury or acute renal failure, I will use these words interchangeably, that acute kidney injury and acute renal failure. Conventionally, it is divided into 3 categories. That's the pre-renal AKI, renal AKI, and post-renal AKI. In pre-renal AKI, there are certain functional changes occur in the kidney. However, the structure of the kidney remains all right. It happens when there decreased perfusion of the kidney, which may be caused by the hypovolemia in condition like acute gastroenteritis, persistent vomiting, diarrhea, or there is acute massive blood loss, such as GI bleed, postpartum hemorrhage, or antepartum hemorrhage, or during an accident. Or the decreased perfusion of kidney may be because of the decreased cardiac output in patients who have suffered from the acute MI or cardiogenic shock, or in those patients who are undergoing the cardiac surgery. And there is some auto-regulation of the renal circulation, and it can be altered if you take these patients the prostaglandin inhibitor, that NSAID, or the ACE inhibitor, which act on the efferent arterioles. So there's some change in GFR will occur. The calcineurin inhibitor like the cyclosporine can also present pre-renal AKI. Then there are certain special entities that is associated with the liver failure, that a patient with hepatorenal syndrome can also have the pre-renal AKI. Renal AKI, also known as the intrinsic AKI, can be because of persistent ischemia because of hypovolemia, or can be because of some nephrotoxic injury, or because of sepsis. Ischemia, nephrotoxin, sepsis, they are the common causes of the acute kidney injury present in a hospital-based population. And there are certain renal diseases such as acute nephritis, patient acute necrotizing vasculitis, acute tubular interstitial nephritis, or if they're the bilateral disease of the renal artery, for example, if both the renal arteries get embolized, the circulation of both the kidneys will suffer, and these patients can have the AKI, acute kidney injury. Then there are certain post-renal conditions. That the kidneys are all right, but the renal outflow system, there is some obstruction comes in a condition like the benign prostatic hyperplasia, prostate cancer, bladder stone, and they are associated with the infection. They with the history of vomiting and loose motion since yesterday. He passed 10 to 12 water stools, and there was no blood and mucus or the pus in the stool. He complained of the mild pain, abdominal occasional vomiting before the act of defecation. Vomiting has reduced after taking some medication from the over the counter. From the local pharmacist took some medication. Vomiting bit reduced, but the loose motion are still continue, and that's why he came to the medical emergency. And when he brought to emergency, when he was questioned further, then he was saying that his urine output, that the urine is coming in the less in quantities as morning. On examination, patient is conscious, his pulse is 88 per minute regular, there is a low volume, blood pressure is 92 by 60 millimeter mercury. Neck veins are collapsed. You cannot see the JVP in this patient. Tongue is a bit dry. Skin trigger appears to be normal. So the so-called conventional signs of the dehydration, so-called that is the sunken eyeballs, loss of skin trigger, loss of the sweating over the axilla, they are the very late signs and may not be present in the patient in the initial stage. And these patients are neglected on, or they are not able to seek the medical treatment, then only they will develop those kind of signs. A systemic examination of the chest, heart, abdomen, and CNS were normal. Immediately, so-called abuse was sent. Abuse is a term which is used quite frequently by the residents who abuse the blood urea and as the serum electrolyte too. Urea is 58 in this patient. Electrolytes sodium 135, potassium 3.3. But I tell that you add the word Busek. That is much the serum creatinine value in this patient. Apart from that, his counts are normal. During the examination, it was a bit pale yellow, no sugar, no protein. Microscopic examination was normal, and by the evening, the ultrasound report was available that the right kidney was 10.2, left kidney 10.8. They are normal, and they're well maintained corticomedullary differentiation. So here there has been some functional change. So what is the dysfunctional? But the structure is well maintained in this patient. So what are you talking about? The functional change, the serum creatinine value, which is marker for GFR, has come out to 1.5 milligram per deciliter in this patient. Is it normal? The serum creatinine value is a good marker of the GFR, but it depends on the muscle mass. It can be the serum creatinine can be within normal range, but the patient can have the GFR in those patients with the, who has got the less muscle mass. Those patients, those persons with athletic good muscle mass, the CNM creatinine may be slightly on the higher side, but there is normal GFR. So the normal value, if you are not you are not able to recall, I will tell that a normal serum creatinine varies from 0.6 milligram to 1.2 milligram per deciliter. So this variation. If it is more than 1.2 milligram per deciliter, calculate the GFR in such patient. So what this patient had? This patient had acute kidney injury. Most likely it's a pre-renal injury because of the acute gastroenteritis and the loss of the volume. What we did in the emergency? We gave out 1 liter of the normal saline over half an hour, and then give at the rate of the 1 liter per hour for that is the total. We give 3 liter of the 3 hours. So his urine output over these 3 hours are noted to the 100 ml per hour. So it is good urine output. And his vomiting stopped, so he was allowed to have the oral sips. His condition improved by evening. His serum creatinine has come back to 1.1 milligram per deciliter. So this is the example of this case is an example of a patient who had the pre-renal AKI, and timely intervention has saved the kidneys and life in this patient. Then I'm taking you to the hospital side. Maybe you are posted or you've done your posting in the labor room. So let's go to a labor room where a 30-year-old lady delivered a healthy baby. On the yesterday evening. Since then, she is having the vaginal bleeding and has soaked 6 pads, and she asking for the more pads. They're still their roots. Resident on duty realized that this bleeding is a bit unusual and arranged 2 units of the pad cell, and it was used overnight. In the morning, they noted on the round that she has not passed urine since morning. There was no history of fever. This patient was giving the injection Movran, that is diclofenac, in case she had a pain, along with the course of the antibiotic, that ceftriaxone 2 gram IV daily, and the metrogyl 500 mg 8 hours. So this was the treatment given. I'm not going in the detailed history of this patient. The past history, the antenatal chart is normal. Her blood pressure is normal in this patient. And so about drug and the family history in this patient. And because of there are some other cases, okay, we are going to discuss. Okay, I'm not going to detail the personal social life of this patient. So on clinical examination, the patient blood pressure was noted to 100/64 per minute. Pulse is 102 2 beats per minute, and she's on dopamine drip to maintain this blood pressure. Her chest and cardiovascular system is normal, but abdominal examination, their tendon is in the suprapelvic area. These were the findings in this patient. Just so the patient was investigated. Her blood urea report is available. That is 6 milligram per deciliter. Creatinine is 1.5, sodium 135, and potassium 4.8. Hemoglobin is low. Counts are normal. Platelets are also normal. So in view of the patient critical condition, she was shifted to the ICU, where she was catheterized. Urine output was measured that it shows only 200 ml. Further, this patient was given the 2 more units of blood transfusion. And she has received about 1.5 liter fluid, including the oral feed. But his urine output on the 24 hours is 500 ml. So she is not oliguria, but it is the urine output on the lower side. On examination, blood pressure has been improved, neck vein has become full, and at the BP blood pressure she is maintaining without dopamine drip. Examination chest has shown the rails on the right base. So this patient has postpartum hemorrhage, followed which this patient reduced urine output and serum creatinine 1.5. That by normal range 0.6 to 1.2. Female, I will say that it should not be more than 1. But again, it depends upon the muscle mass. And probably this AKI has been precipitated by the use of the injection diclofenac, or this patient as it was given for the pain in this patient to relieve the pain. So what after that the patient gives a 40 milligram IV bolus to tickle the kidneys, and urine output improved to 500 ml more. He brought over the 2 hours, that is 100 ml per hour. Her blood urea has come down. Serum creatinine 1.5 has come to 1.3 milligram per deciliter. On 4th, the urine output improved to 2 liter, and serum creatinine has further come down to 1.0 milligram per deciliter. And after this management, we felt that the patient condition improved, bleeding has stopped, so she was shifted back to the obstetrical ward. This is the story of this patient. So this patient had she had the functional changes, but there were no structural changes, as her the renal function is improved by the expert management. So who are the patient who are got at a risk to develop AKI? Those patients who are slightly hypovolemic, who is bleeding, or there can be the loss of fluid in the third space in condition acute pancreatitis, or those patients low cardiac output, are on medication, and the patient who are the elderly patient, they remain, or those patients underlying chronic kidney disease. So there is one entity known as the AKI on CKD. So these patients remain at a risk of getting the acute kidney injury. So how we'll differentiate that whether a patient has gone into the renal kind of AKI or pre-renal AKI? So there are certain parameters just by seeing by the physical examination of the urine, particularly this by measuring the specific gravity or osmolality. Okay, you can differentiate whether the patient pre-renal AKI or the renal AKI. In the pre-renal, urine is concentrated. Okay. The urine osmolality is more than 500, but this is less than 300 milliosmoles per kg of water. Pre-renal, they don't show any proteinuria. The kidney is absolutely normal. In renal AKI, they can have the proteinuria, but usually it is in a tubular range, okay, less than 1 gram. You can see in pre-renal AKI, the microscopic examination is almost normal, but sometimes you may see some hyaline cast. But in the renal AKI, particularly those patients acute tubular necrosis, you can see the brown muddy cast or tubular epithelial cell cast. Or if the patient has acute interstitial nephritis leading AKI, there can be the WBC cast. Those patients with nephrotic illness, there can be the dysmorphic RBC or RBC cast. So that way, by examining the urine, you can make a comment whether this patient is in the renal AKI or the renal AKI. So there are certain other parameters that when you measure blood urea nitrogen in this patient, serum creatinine, that ratio also gives us some idea about whether this patient is pre-renal AKI or renal AKI. In pre-renal AKI, this ratio of the BU and serum creatinine is usually more than 20. And the renal AKI is less than it is in the range of 10 to 15. Then there is the renal indices. The most important indices which is used to differentiate renal AKI from pre-renal AKI is the fractional excretion of the sodium. That is, you measure clearance of sodium with the multiply with the clearance of the creatinine clearance, and make the percent. To make a percentage, you can multiply with 100. Those patients who are the pre-renal AKI, they absorb, the kidneys are normal, so they absorb salt quite avidly. So this parameter, the FeNA, fractional excretion of sodium, is less than 1%, and those patients who suffer from renal AKI, their tubular damage is there. They are not able to absorb the sodium, so it is more than 1%. But sometimes it can be misleading condition if the patient is given diuretic or giving soda bicarb therapy. There's a lot of sodium has been given, or the patient in some disease like the underlying adrenal insufficiency. The patient is not able to retain the salt in those patients, so sodium is excreted more. And certain renal AKI, particularly acute glomerulonephritis, it is found that they have the renal AKI, but still the fractional excretion sodium is less than 1. So let's come to another case. This is Miss Ganga Devi. She is a 26-year-old female, which is admitted in medical ward with complaints of the fever for the last 3 weeks. The fever is present throughout the day, and it ranges from 101 to 103 Fahrenheit. Comes down with the chills when she takes paracetamol for the fever. Before coming to hospital, she consulted a local practitioner of her town, who treated her with tablet Zifi. Zifi is the name for the drug cefixime. Cefixime is commonly used drug, that 200 mg, along with one of the quinolones, that the ofloxacin 400 mg. But there was no change in the pattern of the fever with this medication. She denies any history of joint pain, rash, or abnormal behavior or convulsion. There's no history of cough, hemoptysis, or the burning micturition. When we asked, went to past history, she told that she was diagnosed with some heart disease, that is rheumatic heart disease, when the paper was searched. And she was advised to continue penicillin prophylaxis, that is 1.2 megadose every month. However, she stopped these injections 4 years ago, as she felt that she is totally asymptomatic. It doesn't require it. Her clinical examination: temperature is 102.6 degrees Fahrenheit. Pulse is 102 per minute. She is tachycardic. All peripheral pulses are palpable, and there is no radiofemoral delay. Blood pressure is normal in the right upper limb spine posture. JUP is also normal. There is no pedal edema, no clubbing, there is no rash, no nodes. Nails we couldn't comment to whether as she has applied a nail polish. Coming to cardiovascular system examination, her apical impulse was felt in the 5th intercostal space, mid-clavicle line. There was no thrill. First heart sound was normal. Second heart sound, the pulmonary component was noted to be loud. There was ejection systolic murmur over the apex on auscultation. However, there was no rub. Chest examination, there were bilateral equivalentry and normal breathing. And there were no accompaniments such as the wheeze or the crackles. Abdomen was soft. It was non-tender, and we could not feel any spleen or the liver in this patient. And his renal angle was normal. There was no tenderness. Dental examination was normal, and there was no abnormal movement in this patient. So the lady was admitted in the medical ward with a febrile episode. So what it has to do with acute kidney injury, we'll discuss later on. But still, we thought that what is the cause of the fever in this patient? Is this patient enteric fever, or this patient has developed subacute bacterial endocarditis in view of the history of the rheumatic heart disease? So investigation for the endocarditis was done, that the blood culture, 3 blood culture were sent, along with the CBC and the biochemical test for the liver injury, and the baseline kidney function with the help of serum creatinine and blood urea was also sent. The plan to get the chest X-ray, echo, and ultrasound examination in this patient to find out the cause for the fever. Counts are slightly on the higher side. Hemoglobin, mild anemic, platelet counts are normal. Urea is 24, serum creatinine is normal. So in this lady, the serum creatinine less than 1, so probably she normal renal function. And so there is no evidence of the liver injury, AST, ALT normal. First is awaited, and this patient still, we thought the patient maybe has endocarditis, started the patient on the ceftriaxone and the gentamicin in a dose of 18 to 8 hours. So the echo showed a old vegetation over the anterior mitral leaf plateau. X-ray was normal. Blood cultures in this patient, streptococci were isolated. Fever showed downward trend by the 7th day. So this patient, when the blood culture was positive and there was vegetation of the anterior mitral leaf plaque. So this patient has some evidence of the subacute bacterial endocarditis. And she responded with the treatment for the endocarditis. The fever came down. Urine output is normal. But after 7th week, the next week, when the blood urea and creatinine were measured, the serum creatinine went to 3.2 and the blood urea 102. So almost 4 times the normal. 0.8 milligram was a baseline serum creatinine value. In view of that, but the gentamicin dose was reduced. But still the patient continued to have she complained of the nausea. And the blood urea and serum creatinine went further high. And there was a reduced urine out for the 10th day. So in this patient, the gentamicin stopped, but ceftriaxone continued. On 12th day, the blood urea and serum were still high in this patient. They went higher, further high. That is from 0.8 to 3.2. Then serum creatinine 5.8, and now it is come 7.2. And the patient is complaining of nausea and the vomiting. In view of these symptoms and the decreased urine output, the plan that the patient should undergo the intermittent should undergo the hemodialysis. Hemodialysis continued. There was a temporary decrease in the blood urea, but on the next day it still went up. And after 2 weeks, when the urine output started improving, then the hemodialysis was stopped. And after 2 weeks, the parameter R, the serum creatinine, has come down to 7.2, 2.1 without the support of the dialysis. So what this patient had? This patient had underlying rheumatic heart disease, hemolytic agitation. This patient has got the evidence of the subacute endocarditis, and she has got the evidence of acute kidney injury in front of you. So, what was the responsible for the acute kidney injury in this patient? Most likely, it is the gentamicin toxicity in this patient. But despite of the increased serum creatinine value, the gentamicin dose, the dose was stopped, but it was continued. So it is one of the example of the hospital acquired AKI. The patient suffered from the nephrotoxic injury because of that drug. So to recapitulate, renal AKI or the intrinsic AKI can be because of the persistent ischemia if the hypovolemia or the cardiac output is not corrected, or the patient can have sepsis-induced acute tuberous necrosis. And the third important cause is nephrotoxic tuberous injury, that the drug-induced injury, besides the other conditions which can lead to the intrinsic AKI. Important nephrotoxins which can lead to the acute tuberous necrosis are the aminoglycoside, there is gentamicin, kanamycin, amikacin. So the antifungal drug amphotericin B, which is commonly used these days for the mucormycosis in the COVID patient. Though we are using a liposomal amphotericin B, but still it is toxic. It is not safe. So the kidney function should be monitored when the patient is having the antifungal antibiotic. Antiviral drug like acyclovir can lead to the nephrotoxic injury. Cyclosporine is another immunosuppressive agent used in renal transplant patient. Then there are certain cytotoxic agents, immunosuppressive agents like the methotrexate, ifosfamide, gemcitabine. They can all lead to the nephrotoxic injury and the acute tuberous necrosis. So one should be careful when and the monitor renal function when you are using these drugs in the hospital practice. Let's come to the next case. Okay. So Mr. PC, who is a 28 years old gym trainer, he presented to a medical OPD with complaint of fever, muscle aches, and pain from the last 5 days. So his chief complaint has been fever, myalgia, and the pain for the last 5 days. He noticed some skin rash over his forearm, and it made him worry to visit the hospital. There's no history of cough, burning micturition, there's no headache, or the decrease in urine out. Further, when asked for the past history on the drug history, then he was saying that 2 months ago he went to a hill station for vacation. He sprained his right ankle because of the uneven surface. And for pain, he took some painkiller from a local chemist. And for the last 2-3 days, he's been taking the tablet ibuprofen and the pentoside for the ibuprofen for the pain, and the pentoside, pantoprazole, that is PPI, proton pump inhibitor, which decrease the gastritis caused by this NSAID. It was absolutely fine before that, and there's no pre-morbid illness. Is unmarried. On clinical examination of this patient, is febrile, and a erythematous macular rash was observed on the dorsum of the forearm as well as on the legs. On both the arms, there were thin-like kind of the macular rash was there. Blood pressure slightly systolic on the higher side, both systolic and diastolic, 148/94 mmHg. Pulse 96 per minute, regular. Examination of the chest cardiovascular system is normal, and the abdominal examination there is no tenderness and there's no pelvic mass, and is normal. So this patient has a fever, myalgia, skin rash, that is a diffuse metal rash. Urine output was normal, but blood pressure was slightly on the higher side, 2 times was noted. So what kind of disease this patient is having? Is this patient is having some common viral illness? Or this patient has a certain bacterial infection like the leptospirosis, rickettsial disease, Lyme disease, infectious mononucleosis, that viral infection, or some kind of autoimmune disorder which can present the fever, myalgia, and the rash. You can make a guess and write down. So why this patient I am presenting to you today? Let's see the investigations. Hemoglobin 12.2 gram per deciliter. The WBC count 10,800. Platelet count slightly on the lower side. ESI is raised. CRP is a bit high. Electrolytes are normal, but blood urea and serum creatinine are on the higher side. Blood urea is 58 milligram per deciliter. Whereas serum creatinine 2.8 milligram per deciliter, and by this time everybody should be clear about the normal values of the serum creatinine. Examination of the urine showed the 2+ proteinuria. They mentioned the blood is positive, and so about the leukocyte, that lipstick test. Microscopic examination showed 10 to 12 RBC and 15 to 20 WBC. Urine was sent for culture and as well as for the 24-hour urine examination. And ANA test, why it was done? Usually ANA is positive in patient who has lupus, systemic lupus erythematosus. Any patient present a fever, rash, arthralgia, myalgia, and some changes in the blood parameter. Okay. Suspect the patient can be having the SLE. So, but in this patient, this test came out negative. And the SLE is more the disease of the female sex, but male are not immune to this illness. So in this patient, as the renal function was deranged in this patient, and there was a certain dysmorphic RBC also in this patient, RBC cast. Kidney biopsy was planned in this patient. And there is a history of the intake of certain drug. And the patient blood pressure, then had the blood pressure on the higher side. The patient was started prednisone and given amlodipine. Kidney biopsy procedure went uneventful. For the pain, he was given tramadol and PCM. Kidney biopsy, they said, will be available on 6th day. In the meantime, the culture report came, which showed no growth, and her 24 urine protein is less than 1 gram at 850 grams in a day. This is the urine microscopy, which is showing a lot of WBC. WBC, and this is the WBC cast, and the RBC are also visible. And this is the biopsy, kidney biopsy slide. Anybody can interpret it. So mostly in this patient, when we see the kidney biopsy, this is a glomerulus. Slide there increase, you can say there is slight increase in the mesangial cellularity. But main findings are in the interstitial compartment and the tubules. The tubules which denuded. There is the interstitial, the lymphocytic kind of infiltration in the interstitium. So This patient has acute interstitial nephritis, maybe because of ibuprofen. He was a few days back. He started taking ibuprofen as well as PPI. Proton pump inhibitor also found out to cause a cause of acute tubular interstitial nephritis. So it is the ibuprofen or the PPI, just a wise guess. But both these medications were stopped in this patient. Prednisone continued in this patient. With that, the fever subsided, and within 2-3 days, his serum creatinine has come down. He didn't require any dialysis. So that was another case where the patient suffered from the AKI, which is the intrinsic AKI, because of the acute tubular interstitial nephritis second to a drug. And the drug which are responsible for the acute tubular interstitial nephritis are the penicillin, sulfa, cephalosporin, sometimes rifampicin, allopurinol, and the PPIs also. They can lead to the acute tubular interstitial nephritis. Then coming to the next case, again this is an OPD case where a 15-year-old schoolgirl came with a history of the swelling or the face, that is, the face has turned puffy for the last 5 days. And she noticed that the color of the urine has become a bit dark and the quantity has decreased. And there's no benefit of taking a lot of water. She initially thought that it's summer season. Why should not take a lot of water? But still the urine output is decreased in this patient and the urine color is dark. She has also noticed swelling of the feet for the last 3 days, which is a bit worrisome, and the patient was brought to the OPD. She denied any history of joint pain or skin rash. However, in the past, she said that she had a sore throat and fever 3 weeks ago. Consulted a dispensary doctor who prescribed her azithromycin, that is macrolide antibiotic, for 5 days, and to do the saline gargles. So the fever and the sore throat recovered. She denies intake of any other medication. She's vegetarian. She has attained menarche, and cycles are normal. Clinical examination showed the face is puffy in this patient, the face swelling, as well as the fetal edema. Blood pressure is 152/100 on the higher side. Normally, the adult is 140/90. That's the upper limit. Pulse 86 per minute, good volume, regular. There's no pallor. Examination of the neck, he showed a small non-tender non-metal lymph node. There's no skin rash. Throughout examination came out to be normal. JP is normal in this patient. No clumping. Chest examination. There is normal breathing. Bilateral equal entry, and there is no crack of the wrong kind. Same, the cardiovascular system is normal in this patient. And abdomen, there is no tenderness, and there is no evidence of any mass or the organ. So this young girl presented in the OPD with the facial swelling, and decreased urine output, which was acute onset. This 5 days history. Blood pressure on the higher side, dark colored urine. Urgent urine examination was done, and other investigations such as ECG, CBC, KFT, LFT, complement, C4, ASL titer, they were all sent to. Urine dipstick, which is easily available, came out of proteins 2+, and the RBs were dipstick, there are 3+. This was urine gross examination of the patient. This is dark reddish color. And when you see the under microscope, there are a lot of RBCs are there. It's dysmorphic RBC, and there is the RBC cast. So a patient is having the edema, hypertension, and the other renal function. Okay, in this patient, that the report of the blood urea is 48, serum creatinine is noted on 1.6. Okay, that was the report. Okay, which I didn't enter here. Okay, but so this patient has nephrotic illness. Okay, advised to have salt acid diet, starting on the furosemide, that loop diuretic from the amlodipine. She was advised to monitor her weight and asked to come with the OPD with the reports. These are the reports of the patient. That is, hemoglobin is 11.5 gram per deciliter, platelet normal, but serum creatinine is a bit higher side. ACLT normal in this patient. Serum albumin is slightly on the lower side. ECG came normal. ASLO titer is 400 unit, and complement levels are also low in this patient. So this patient has hypocomplementemia. ASLO are high in this patient. So what is the most likely diagnosis? Okay, this is follow up the patient. That with the treatment, okay, fetal edema subsided, urine output improved. In view of the impaired renal function, the option for a kidney biopsy was discussed with the patient. However, they deferred and they told to continue the medication for blood pressure as well as to decrease the edema. And when they came on next visit, her blood urea came on 48 and serum creatinine came down to 1.6 milligram per deciliter. So this patient acute nephritis, classically most likely she has post-streptococcal nephritis, which has shown the recovery, and on the follow-up we'll come to know whether the patient recovered fully or not, because all the patients may not show the complete recovery in this patient. So the next case, okay, the patient is 68-year-old male who is retired from government service, and he was brought by his wife to medical emergency with a complaint that the patient not feeling well for the last 5-6 days. Patient also complained of the pain and burning while passing urine. And since today morning, he's complaining of pain in the lower abdomen and unable to pass urine, and that's why he's brought to medical emergency. The history of nocturia, that the patient is passing urine at night 3 to 5 times at night. Okay, there is increased frequency as well the patient nocturia also. Consulted a general practitioner who gave him amoxicillin and the tablet pyridine, and asked him to undergo certain investigation. Further, asked a history of the patient hypertensive from last 8 years, and is taking tablet amlodipine and the hydrochlorothiazide, which is a thiazide diuretic. On examination, patient is is looking quite anxious. Pulse is 90 per minute regular. Blood pressure 150 on the higher side, 152 by 104. Chest exam is normal. Per abdomen, there is a tenderness over the suprapubic area in this patient. Investigation done in the emergency showed the serum creatinine on the higher side, 3.2. Potassium is also high, 6.8 milligram per liter. Counts higher side are normal, platelet counts are normal. In view of the lower urine tract symptoms, okay, this patient was having the pain and burning sensation. The urine was sent for the routine and microscopic examination as well as the culture. Is this patient an AKI? We don't have any baseline value, but any patient who comes for the impaired renal function where you don't know the baseline renal function, suspect the patient having the acute kidney injury. So this patient AKI as well as is having the hyperkalemia. A fresh sample was sent for serum electrolyte. Urgent ECG was done to confirm the whether this is the dangerous kind of hyperkalemia. Urgent ultrasound was performed as he was in tenderness. It showed a distended bladder and the bladder was catheterized, drained out of 700 cc of the urine. So this is the ECG report of the patient where the peaked T wave, tall tented wave, which is a sign for the hyperkalemia. And this is process, and this is bladder. Bladder is distended here. This is prostate. Protein shows urine examination. Protein shows traces. Sugar is nil. Microscopic urine examination showed that the full pus cells. Culture report came on third day, showed the E. coli. So again, this patient was acute kidney injury. Secondary to obstructive uropathy, that is the BPH in this patient, along with the urine tract infection, hyperkalemia. This patient, as a patient with hyperkalemia, which is on the dangerous level, so the hyperkalemia was managed by giving the calcium gluconate, dextrose, and the short-acting insulin and the salbutamol nebulization. Telmisartan. This patient was taking telmisartan to control the blood pressure. This telmisartan can also lead to hyperkalemia, so it was stopped, and the patient was told not to take any fruit or fruit juices. Started on a course of antibiotic, ceftriaxone and ofloxacin. On the fifth day, it showed the signs of recovery. Serum creatinine came down, counts also decreased within normal limit, and the patient was from the IV antibiotic was switched to the oral antibiotic and referred to the surgical OPD. So today I will discuss the topic of the AKI by showing you and discussing certain patients who had a different problem. One patient with common illness, that acute gastroenteritis. Second patient in the labor room. Third patient was taking some drug and suffered from acute nephritis. Then came a school girl, which had got a nephritic illness. And then lastly, I discussed the elderly person who had the AKI because of the obstructive uropathy, that the post-renal AKI. Again, with a good nephrology services, they say that nobody should die of the acute kidney injury. So still the mortality of the patient who present with acute kidney injury is quite high hospital population. Early recognition and the timely intervention can improve the outcome in this patient who suffer from the acute kidney injury. Yes. Yes, Dr. Keshav, he asked, sir, in the first case, do we check blood pH? That a role of checking the arterial blood gases and the pH examination in the patient with acute kidney injury. In the first case, as we thought this patient is having the acute kidney injury, which was because of the pre-renal. So in all the patients who have AKI, we don't do the ABG. But those patients where the patient is more sick, maybe acidotic, in those patients we monitor it. That is the theoretical kind of the answer. The patient is having the diarrhea, maybe losing a lot of soda bicarb in the alkalosis. The patient improved in front of you. Yes, it is good. It is a most of the theoretical question. If there's some exercise on the ABG comes, then what is the cause of this metabolic alkalosis in the patient with AKI? So still the patient has mild AKI, doesn't still the renal function are normal, are not grossly deranged. Yes, which case? This was a patient, right basal crackles signify you. See, only the presence of the crackles in the lower 1/3 on one side may not carry any value. But when you see there are the other signs of the fluid overload, the JP is full, some patient, blood pressure is quite good. It indicates the patient is going towards the fluid overload. HUS, any patient who has diarrheal illness, and if they suffer from the acute kidney injury, this diagnosis of the hemolytic uremic syndrome is entertained. The condition is known as the thrombotic microanchopathy, which is a two phenotypes. One being the TTP, thrombotic thrombocytopenic purpura, and second being the HUS. In TTP, the patient is having neurological signs, as well as they can have the impairment of renal function. HUS classical in the pediatric age group. This is because of the Shiga toxin produced by the E. coli. So this is a quite severe kind of AKI, and some where the patient, some of the patient, if you give the early antibiotic, you can prevent it. Otherwise, they don't behave so well. Atypical HPS, there is a role of the plasmapheresis, as well as if you give the eculizumab to this patient. So it is a complement mediated injury in this patient. So you can treat it. PSGN crescentric. Oh, no, that was the biopsy. We didn't do that in the patient. When the patient recovered, okay, PSGN, usually they are having the endocapillary glomerulonephritis. The glomeruli, they are quite full. There's a leukocytic infiltration, as well as there endocapillary endocapillary proliferation. That is the classic of the PSGN. Yes, some bad cases can have the crescent too. So the one of phenotypic pathological phenotype of the PSGN could be the crescent too, but it is a bit rare. Yes, there is a classical PSGN present as a nephrotic syndrome only. Okay. Cystitis progression to the pyelonephritis. Okay. This question, okay, not. Any other question which is left? If not, then I see you again at 11:30 for the to see the other patient of the problems of the CKD. हेलो। हाँ नमस्कार ना। बस ठीक। वो कि आपको भी मोबाइल दूरी सब ठीक ठाक दे जाती है। कहाँ पर? इतनी गर्मी में और इस साल में 1 डिग्री 1-2 डिग्री और भी ज्यादा टेम्परेचर होता है इस साल। चलो 20 से आराम से जाओ। मैं एक लेक्चर दे रहा हूँ। हाँ 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 हाँ। ठीक है। क्या 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 आपको कॉल करनी है? Hello. Can we discuss a second topic that approach a patient with chronic kidney disease? If you are all on your virtual platform, just raise your hand if you can start. Or all right, okay. So after introducing and covering some cases with acute kidney injury, I will discuss some cases and approach a patient who having a chronic kidney disease, and that will complete more than 60% of the renal medicine and will touch most of the topics which relate to the subject of the renal medicine. So before we go further, I will come to know that a patient is having chronic kidney disease. I will briefly present 3-4 cases, and then we'll make some conclusion. Okay, what these patients are really having, what the problem of the patient, and after that we'll go to the topic of chronic kidney disease. I will discuss a bit about the etiology and the clinical feature. And in this patient, the management of the patient with chronic kidney disease and their problem is really a practical problem. I will go into the management with detail. So let's see what is your first case. This is a 25-year-old young man who was told to have high blood pressure 1 year ago. He didn't bother much. Sometimes he used to take medication, sometimes not, and has come for the expert opinion. His blood pressure was noted to 162 by 100 millimeter mercury. Pulse is normal. He has got a mild pallor. Systemic examination normal. Does this patient, young man, have a chronic kidney disease? That is the first case, and the question is that really is this patient in chronic kidney disease? Otherwise, this patient is absolutely asymptomatic. Sometimes complain of the headache that goes off, but he heard by some of the friend that one of their friend had the problem of the high blood pressure. They ended with the dialysis. There is another patient of this question that interrupting my slide. How can I remove it? Okay, if you can help me out, yes, I can take it further down. This will be the right place. So, a 56-year-old male who was diagnosed to having diabetes from last 5-6 years. He was on oral glucose lowering agent and seemed that there was no problem. But from the last 1 year, he complained of the weakness and the easy fatigability, and has developed the swelling for the last 6 months. That was the point of worry and made him consult an expert. On examination, he has a mild pallor, he has a mild pupillary edema. Blood pressure is 152 by 96. Pulse 86 per minute, it is regular. Systemic examination of the chest, cardiovascular system, abdomen, and CNS has been found out to be normal. So, is this patient with chronic kidney disease? The question arises. Then another patient, 48-year-old gentleman, told to have cyst in the kidney during a medical examination. He undergoes ultrasound. Also, they told there is some cyst in the kidney. Otherwise, he's totally asymptomatic. Blood pressure 140 by 92 millimeter mercury. Pulse is regular, 84 per minute. Chest and cardiovascular examination normal. Abdominal examination found that the kidney on the right side by manual examination is palpable. Otherwise, then not able to feel any cyst. Surface is smooth. Is this patient in a chronic kidney disease? That the question arises. Then there is another person who was sitting idle in the dialysis unit. He came to the OPD. The question that my relative had a kidney disease and I wanted to go dialysis. Do I have chronic kidney disease? Doctor, tell me, is there something wrong with my kidney? Or my kidneys are okay? So these are the various types of patient, a person who will come to you and will ask the question that मेरी kidney ठीक है या खराब है? As chronic kidney disease, as we know, the prevalence of the disease is about 10% in the population. You say 10% is a bit alarming, isn't it? And majority of these patients remain asymptomatic till they have got the advanced disease. So that's why I brought this topic for the discussion. And these are the 4 cases. One patient had increased blood pressure. Second patient was having the high blood sugar level. Third patient was just had a cyst in the kidneys. And this was the 4th person who just came for a consultation. So, do these patients have chronic kidney disease? So at least before we approach a patient that is a chronic kidney disease, we should know that is this patient really in chronic kidney disease, and what are the when we are going to say a patient with chronic kidney disease. Again, the story of chronic kidney disease started the chronic renal failure. That a person is having the progressive decline in renal function over months and the years, which is caused by the irreversible loss of nephron. So that was some kind of the vague kind of the definition. But over the last 20 years, the renal physician and nephrologist reached some kind of consensus, and this came with the definition of chronic kidney disease. To call a patient who has chronic kidney disease, he must have evidence of kidney damage at least for 3 months or more. What can be evidence of renal damage? The patient can have the abnormal urine examination, albuminuria, proteinuria, or can have the abnormal kidneys. There is small strengthened kidney or scarred kidney. Or if you undergo kidney biopsy, there has some evidence of the chronicity on the kidney biopsy examination, with or without an evidence of function impairment of GFR. At least the patient should have the evidence of kidney damage, and he may have the reduced GFR or may not have the reduced GFR. Or in a patient you are following up, if you measure a glomerular filtration rate, and if you find out that this glomerular filtration is persistently low over the last 3 months and is not improving, then with or without the evidence of the kidney damage, the parameter which I shown told to you, and the GFR is less than 60 ml per minute, you can label this patient as having a chronic kidney disease. So chronic kidney to diagnose chronic kidney disease, usually we have got the 3 parameter at least. urine examination, then the serum creatinine, and the third, some imaging technique. Kidney biopsy is rarely required. So for the AKI, I talked about two parameters. That a reduced GFR, the serum, that is increase in the serum creatinine value, and the decrease in the urine volume over the 6 hours. That are the two parameters. But now, if I add to these parameters, if I add the urine examination, GFR and ultrasound, it make you easy. It make it easy to diagnose a patient to have chronic kidney disease. Chronic kidney disease, on the basis of the glomerular filtration rate, it divided into 5 stages. Normal GFR varies between 100 to 120 ml per minute. And in stage 1, it is not normal, but it is more than 90 ml per minute. Stage 2, it is more than 60 but less than 89 ml per minute. Stage 3, it is less than 60 ml per minute but more than 30 ml per minute. Stage 4, it is less than 30 ml per minute but more than 15 ml per minute. And stage 5, where the GFR, if you're measuring GFR, is less than 15 ml per minute. This was the staging which has been done for the chronic kidney disease, which has been updated now. And there is another parameter which is added, the protein creatinine ratio, PCR. By addition of this parameter PCR, we can do the risk stratification of the chronic kidney disease. And further, this stage 3 is further divided into 2 stages. Stage 3A and 3B. 3A is the GFR between 45 to 59 ml per minute. And stage 3, when the GFR is between 30 to 44 milli. Then this PCR, there are the 3 categories of PCR. One being the green is the normal group. That is the protein creatinine ratio in milligram per gram of creatinine. If you calculate it, okay, it is usually less than 30 ml. Stage, this is the A2, okay, where it is in the range of 30 to 300 milligram per gram creatinine. And the stage 3, this A3, where it is more than 3, it is a clinical kind of proteinuria. So, when there is a clinical proteinuria, along with the CKD stage, these they are bad prognosis. They behave worse out of these categories. The green category, stage 1, 2, they are fine. But if they've got some proteinuria, again, they go into high risk category. So on the basis of this PCR, okay, we do the risk stratification in the patient of chronic kidney disease. So when you're going to guess or revise that the patient is having at a risk of getting chronic kidney disease, there are certain categories. Okay. Those patients who are hypertensive, diabetic, smokers, obese, those with a family history of chronic kidney disease, which were having a prolonged use of the NSAIDs, painkiller, and even the aging. Okay, after the age of 30, okay, there is a decline in the GFR by 1 ml per minute every year. So by the age of the 70, the normal GFR becomes 70 ml per minute. That is already in stage 2. But it remains a point of debate where these kind of normal function we call as CKD or not. But these patients remains at a risk of chronic kidney disease. Acute kidney injury. Though the acute kidney injury they recover, but recovery may not be complete. So If the recovery happens within 48 to 72 hours, the prognosis is quite good. Probably the disease has reversed back. Those patients where they have got some kind of the abnormality which persists beyond 7 days, these patients are at a risk of getting the chronic kidney disease and may they require the dialysis in the long run. Low birth weight, the child which is low birth weight also remains at a risk of getting a chronic kidney disease. So if you find out that these are any of these factors are present, to start guessing, is this patient having chronic kidney disease? So the important causes of the chronic kidney disease are the diabetic nephropathy, hypertension, sclerosis, chronic glomerulonephritis, chronic TIN, renal calculus disease. Then there is a certain heredofamilial disease such as the Alport syndrome, Alport disease, and the Fabry disease. Then there are certain immune-mediated kidney disease like the SLE and the renal lupus nephritis, renal vasculitis. Certain genetic disease like the polycystic kidney disease are the important causes of chronic kidney disease. Recently, there were in certain group of patients, particularly farmers and the workers who are working in the hot and humid environment, a derangement of the renal function has been seen. And this has been brought to highlight in the category of CKD of unknown etiology. And a lot of factors play a role why these patients have gone into chronic kidney disease. Why the patient gets a chronic kidney disease? This patient has some kind of initiating mechanism. In the form of they can have some disease or some nephrotoxic injury or some genetic mediated injury, which damage the renal nephron, which lead to the release of the cytokines and the cytokine mediated injury, leading to glomerulosclerosis and the loss of the nephron. And once there is a loss of nephron, the kidney adapts by hyperfunctioning of the remaining nephron, which get the hypertrophied, and they do the hyperfiltration. And as a result of that, they get the hyperfiltration injury and progress to the, and their kidney disease progresses. Most of the patients with chronic kidney disease, stage 1, 2, 3, they usually remain asymptomatic. They may not have the much of symptoms. Stage 3 onward, particularly stage when the GFR is going less than 60 ml per minute and reach about 45 ml per minute, some kind of the nitrogenous waste they start accumulating in the body. That is, blood urea is slightly on the higher side. Serum creatinine is slightly on the higher side, maybe 1.3, 1.4. And these patients, they have only the minimal symptoms of the mild symptoms. So the azotemic stage is a stage 3 and 4. And a symptomatic stage, but late stage of stage 4 and stage 5 when the GFR goes less than 15 ml per minute, these patients invariably become symptomatic. Symptoms are but non-specific. They complain of lethargy, tiredness, effort, intolerance. Maybe because of the anemia in this patient or the bone disease, this patient complain aches and pains or bone and joints. Advanced stage, they complain of the itching, pruritus all over the body. They become nauseating. They start having nausea and become mildly anorexic and develop the swelling over the feet or the body. Complain of the weakness of the proximal muscle weakness. They are not they feel tired when they get up. And in the stage 5, if the patient is not treated, these patients can have the CNS symptom. There's the alteration of sensorium in this patient. Started with the impairment of judgment, and these patients can have a myocardial jerk, can have convulsion, and will lapse into the coma. Clinical signs in this patient too. This patient can have a pallor, that is a sign of anemia, can have edema, itching mark, hyperpigmentation, half and half nail, classic distal half of the nail is slightly pinkish. Pulse is quite bounding in this patient because of the hypervolemia. Blood pressure is usually high. They have the ecchymotic spot and they have the bruises over the body. Uremic cross too. That is the deposition of the urea over the skin. These usually we don't see, but early in the marked urine patient, those kind of the signs were seen. So these signs, which as I described, they are seen in advanced stage of the chronic kidney disease. Clinical examination of the various system of cardiovascular system, they can have the flow murmurs because of the anemia, or can have the pericardial rub because of uremic pericarditis. Chest examination can have the bilateral crackles because of the fluid overload. Abdomen is usually unremarkable, but for a patient with polycystic kidney disease, where you can palpate the cystic kidneys. CNS examination, depending upon the stage, there can be variable kind of the signs. The patient can have the flapping tremor, can have the impaired judgment in this patient, and they become drowsy. So, musculoskeletal examination, they complain the pain over the joints. When you and that they have the proximal muscle weakness. If you're going to see the muscle strength in the patient with chronic kidney disease. So to diagnose a chronic kidney disease, you need 3 parameters: urine examination for the albuminuria, or some evidence of some cast are there. In patient with a chronic kidney disease, you get the broad cast, because they are coming from the hypertrophied nephron tubules. GFR is important, and for the GFR we calculate the creatinine clearance, which may slightly give the higher kind of GFR. And to make a true value, we can take the help of the radionuclide clearance, that iodine 125 clearance. Imaging of the kidney, if you have bilateral shrunken kidney or polycystic kidney disease, this will help in diagnosing the chronic kidney disease. Proteinuria, urine examination. Proteinuria can be checked with the help of the dipsticks or some precipitation method, like by adding the sulfosalic acid, the urine, or you can have the quantity measurement of the proteinuria. The dipsticks examination of the urine protein is negative. We test the urine for the presence of the microalbuminuria. Microscopic examination, the RBC cast or the WBC cast or the broad cast, they are the seen in patients with chronic kidney disease. You may see the RBC, WBC, or tubular cast, which is more than 3 RBC, which is dysmorphic RBC, more than 5 WBC, and the renal tubular cast, they are abnormal. For the measurement of the glomerular filtration rate, we take the help of certain equations. Can we call this estimated GFR? There are various equations are available. And for the patient with chronic kidney disease, we use the MDRD equation. There is another equation, CKD EPI equation is also available to calculate the GFR. And there is the Cockroach formula. With the help of that, you can measure the GFR in these patients. But in patients, okay, you want to exactly measure the GFR. Then we take the help of the radionuclide agent too. That is iodine 125, iothalmate clearance, okay, we do it. Or maybe you measure the classical method of the clearance by collecting the urine over the 24 hours, calculating the concentration of the creatinine in the urine and plasma, and with the rate of formation of the urine. That way you can calculate the GFR. The classical teaching of the physiology that the insulin clearance, we usually don't do in the clinics. Then these are the various investigations, okay, which should be done in a patient of the chronic kidney disease: the blood urea, serum creatinine, electrolyte, calcium phosphate, alkaline phosphatase, vitamin D level, PTH level, blood pH, important to in patient chronic kidney disease. Complete hemogram including the iron studies, and those patients with anemia, okay, particularly macrocytic anemia, you do the measurements of B12 and folate level. Lipid profile, ECG and ECO are quite important, okay, to see the effect of the hypertension, okay, on the heart, okay, because these patients who have chronic kidney disease are at an increased risk of getting the cardiovascular event. Again, okay, along the ultrasound, we can do the renal Doppler of the renal artery, okay, where we suspect the patient can have the chronic kidney disease because of the renal vascular disease. The role of the kidney biopsy is a bit limited, okay, in patients with chronic kidney disease. But in those patients where the cause of the chronic kidney disease is unknown, and still the patient is normal sized kidney, then these patients can be subjected to the kidney biopsy to find out what disease, what the etiology of the disease by subjecting into the genetic studies. Now come to the management of the chronic kidney disease. Once you diagnose the chronic kidney disease with the help of the 3 parameters which we talked to you, okay, that is urine examination in this patient, okay, GFR with the help of creatinine clearance, okay, and the imaging study, we establish the patient with chronic kidney disease and stage it. In some patients, the cause of the chronic kidney disease is obvious, and you write down this is the most likely cause. And once you have made the diagnosis, then while managing a patient, the focus is on how can we reduce the rate of progression of disease. Invariably, the chronic kidney disease progress over the time. Over the time, okay, these patients develop various complications. I will discuss with you. Those patients such as anemia, edema, bone disease, cardiovascular problem, they have to be managed well. These patients have a lot of metabolic problems also. So appropriately, these complications have to be managed. And once we declare the patient has gone to chronic kidney disease, that is advanced CKD, to maintain the life further, we have to take the help of either some dialysis support, or or if some donor is available, we do that. So the stage management of stage 5 is really in the field of the nephrologist. So to reduce the progression of the disease, some patient can have the nephrotic syndrome because of the maybe membranous nephropathy, maybe FSGS. So if we control the nephrotic state with the help of the medication, probably you will prevent the progression of the disease. Similarly, new lupus nephritis, starting the immunosuppressive agent, steroid, or the calcium inhibitor, we stop the progression of the disease. Usually, the nephrotoxic drugs, infection, hypovolemia, these are the causes of the acute kidney injury on the CKD. If the patient is having these kind of exposure to nephrotoxin, or has got the hypovolemia, it should be treated. And if there is infection is there, it should be recognized at the earliest, should be treated. So if we recognize the acute kidney insult to treat it well, and you may reduce the progression of the disease. If the patient underlying obstructive uropathy, take the help of the surgeon or the urologist to relieve the problem. If a patient diabetic nephropathy, suppose I present one patient to the second exercise, the diabetic patient, serum creatinine was high. So can we stop the progression of the diabetic nephropathy? Various studies like UKPDS studies was there in type 2 diabetes. So it is shown that if you control the blood sugar in this patient, control the blood pressure in this patient, you can reduce the rate of progression of other chronic kidney disease. Similarly, as I talked to you, if you treat the patient with nephrotic syndrome, lupus nephritis, probably we minimize the progression of the chronic kidney disease. So how can we slow? Are there some other methods which can slow down the progression of the chronic kidney disease? Particularly, there the role of diet is there. If the patient is not malnourished, so when the patient is already malnourished, we should not do the protein restriction. Those patients whose serum proteins are normal, albumin is normal, there is no sign of the muscle loss. In this patient, if we restrict the protein to the level of 0.6 gram per kg body weight over the time, or we give a very low protein, that is, we give the protein and the 0.3 gram per kg body weight. So these patients, when the very low protein, they get the risk of getting the malnutrition. So usually we restrict the low protein diet, that's the diet of about 0.6 gram per kg body weight, and it is shown that in these patients the GFR doesn't decline that fast as compared to those patients who are having a normal protein diet, that's the 0.8 to 1 gram per kg. Then treatment of the hypertension. The blood pressure should be optimally controlled. And optimal control, the blood pressure should be less than 140/90. If the patient is diabetic, particularly, and the proteinuria is less than 1 gram in this patient, then here the goal of the target for blood pressure control is 130/80. Further, if the patient has proteinuria more than 1 gram, then we still lower the target of the blood pressure to 125/75 limit of mercury. So by maintaining the blood pressure in the normotensive range, we can decrease the progress, we slow down the progression of the chronic kidney disease. Then the advanced stage, the patients start getting complications. So here beside or taking the measures of the reduction of the progression of kidney disease, our focus goes to the management of complications. The patient of chronic kidney disease, they become anemic because the reduced production of the APU in this patient. They become edematous because of fluid overload. They can have the mineral bond disorder either because of vitamin D deficiency or the increased PTH level. And these patients, if they have the underlying cardiovascular disease, it should be treated well. And in the advanced stage, these patients invariably develop metabolic acidosis and hyperkalemia, which should be tackled and should be treated well. For the management of the anemia, we assess the iron status in the patient. That if in this patient the T set is less than 20%, or a serum ferritin is less than 200, so it indicates the patient is anemia, or this indicates the patient is iron deficiency. So these patients must be supplemented with the iron therapy. And in the patient of chronic kidney disease, giving the parenteral IV iron is better than giving the oral iron, because invariably the compliance of the patient to the oral iron therapy is less as compared to IV iron therapy. Along with that, they are giving the erythropoietin therapy or erythropoietin stimulating agent. And recently, there are certain agents that come because both the erythropoietin and erythropoietin stimulating agent, like dermopoietin, they have to be given subcutaneously. So the oral form of the medication, like the HIF inhibitor, has come, which also maintain the hemoglobin level in this patient. The patient is in the folate deficiency, particularly those who are on dialysis, it should be supplemented well along with the vitamin B12 supplementation. Then mineral bond disease is another important issue. These patients complain of the bone pain. They can have proximal muscle weakness. Sometimes they can fracture also. They can be they do osteopenia, and they develop the vascular soft tissue calcification. So this disease is usually because of the increase in the fibroblast growth factor FGF23, which I must have discussed with you in my theoretical lecture. Phosphate retention and decreased production of the vitamin D by the kidneys. And the secondarily, to maintain the calcium level, the PTH level increases, and perhaps in this way PTH, it lead to the demineralization of the bone. So they should be controlled from the very beginning. They should have the restriction of the phosphate in the diet. Usually the phosphate is in the dairy product or in the meat diet. So you cannot totally abolish these protein diet from the patient. Otherwise, he will go to protein and malnutrition. So for that to decrease the phosphate level, we take the help of the phosphate binder, which are calcium based, or there are certain resins like the Revlimar is available. with the help of these phosphate binder, usually we control the phosphate in this patient. This patient, if they have hypocalcemia, we do the calcium supplementation along with the vitamin D3 supplementation regularly. For the management of the edema, usually we take the help of the diuretic, and if the patient goes into a resistant kind of edema, and if we do low, that may be the stage of the dialysis. Persistent metabolic acidosis has got the negative effect on the body. These patients become cachexic. They feel fatigued. So in this patient, they are giving the soda bicarb daily to maintain the soda bicarb about 20 millimole per liter. The patient develops hyperkalemia. That is again seen in the advanced stage of the chronic kidney disease. We restrict the diet rich in potassium, like the fruit juices, nuts, and if it is a hyperkalemia quite dangerous, we take the help of emergency measures to control the hyperkalemia, like we get calcium gluconate, as I discussed with you when I discussed the management of acute kidney injury. You get glucose, you can give soda bicarb, which transfer potassium from the extracellular compartment to the intracellular compartment, and can take the help of salbutamol also, which also helps in the control of the potassium in these patients. Management of advanced CKD stage, the GFR goes less than 15 ml per minute. This is the advanced stage. And when to start a dialysis? Not all patients who are having the GFR from 10 to 15 ml may not require dialysis. The patient, if the life is reasonably maintained, the help of the medication, they were good urine output, then these patients we still can wait. But when the patient has got the end stage kidney disease, the GFR has gone near to 5 to 7 ml per minute. Invariably, these patients start having complications and need the renal replacement therapy. Renal replacement therapy can be in the form of dialysis. Usually, it can be intermittent hemodialysis, twice in a week, or we can take the help of peritoneal dialysis. Choice between the hemodialysis and peritoneal dialysis should be the mutual discussion and the availability of the resources with the patient. Those patients who can have the donor, mostly in our country, we are doing the live kidney transplant. And rarely we do the deceased transplantation also. We take the kidney from a deceased person and the transplant, but it is less than 1%. Mostly the kidney transplantation is from the live donor, and they are the related one. If they are available, after the matching and the other procedures, screening, we go for the kidney transplantation, which is a better option. So today, with the help of the certain cases, I discussed with the problem acute kidney injury and how should we approach it. That is, first we diagnose whether the patient acute kidney injury or not, and then we go accordingly. How the patient is. Then we discuss. I briefly presented some examples of the chronic kidney disease, and to find out whether patient chronic kidney disease or not okay, I took the help of a certain parameter. Again, to repeat okay for the urine examination, to know the patient is having the some kind of the kidney damage, or the calculation of the GFR in this patient, or some imaging of the kidney, which can tell you about whether this patient is chronic kidney disease or not. I stratified the chronic kidney disease and stratified on the basis of proteinuria. I discussed the various measures of how can we reduce the progression of chronic kidney disease. And at the end, okay, we discuss the management of the advanced chronic kidney disease, stage 5, when the patient is becoming uremic. So if there are any question, okay, the next session, the question answer session, okay, you can send your question to me, okay. I will try to. Is there any question? Okay, please type your question, okay, in the question box. Yes, any question? Yes, Alicia. If there is no question, then I'm closing this session. And you can send your question on email, or we can discuss when there will be live classes.